Hello, everyone, and welcome to another audio podcast in this series. The LabTronix series. This is an RPSG and KDOS collaborative. This is an audio podcast as part of the Ballistix Edition on renal pharmacy and medication. And once again, this is the Shientist, and as this is part of a Storm Robotics production. So to begin with, I'm gonna highlight some context in regards to polypharmacy. Polypharmacy generally is an effect, and that is a continuous use of multiple drugs to treat a single disorder or conditions. And this works by team in 2017 that have highlighted sort of definitions around polypharmacy. The lack of transparency and universal definition of polypharmacy, albeit minor, moderate, and major, makes it generally challenging for healthcare professionals across healthcare sectors to best advise and when considering drugs in aligned to particular conditions, also the efficacy and in aligned to sort of best practices. Multiple medications are poorly defined in literature in some regard, and there are several definitions which can add complexity. Polypharmacy generally is associated with adverse outcomes, including mortality, falls, adverse drug reactions, and length of hospitalizations as well. So the phenomenon of multiple medications is directly related to the number of comorbidities or multimorbidities, and CKD patients can be prescribed multiple multiple medications to prevent progression of disease, but also help manage some of the attributed comorbidities or multimorbidities that some may encounter. And so, as more medications are generally added to control complications of CKD, such as, for example, metabolic disorders, bone disorders, anemia, amongst others. And also, multiple medications might have complex interactions with foods and nutrients, which could lead to compromised nutritional status. A recent study informed that CKD patients have higher prevalence of inappropriate medication prescriptions, mostly antibiotics and antihypertensives, and it often implies a negative situation involving unnecessary use of medication, and therefore this has become sort of a concern in regards to healthcare management. And the most known predictors for polypharmacy, for example, can be implementation. Polypharmacy implementation can include, for example, age. Those from a female gender have a sort of predominance in context around polypharmacy, poor self-reported health, and also where there can be evidence of low educational status as well. Now, I'm going to talk in the next few slides. I'm gonna highlight some aspects in regards to different different viruses or vaccinations, and apologies in advance where some of this may be a repeat or repetitive or a repetitiveness based on a previous audio podcast in this LabTronix series, but in keeping with this theme, I thought I'd provide an overview around these particular areas of practice as well. So a bit about hepatitis B virus or HBV and the vaccination around that. So advanced age those from the male gender, those who have previous, for example, blood transfusions, are associated with poor seroconversion rates. And patients with CKD must be immunized or should be encouraged to be immunized as soon as possible, and before, for example, starting any form of renal replacement therapy where possible. The use of HPV vaccine or vaccination and preventative measures have helped reduce the annual incidence of HPV infections in patients on different forms of renal replacement therapy. And it is important to vaccinate CKD patients, and recommended vaccination schedule is anything from where there's 4 doses of around 40 micrograms of particular HPV vaccination at sort of time points where there'd be at 0 months, 1 month, and 2 months, and at 6 months, or 3 doses of 20 micrograms of HPV vaccine or vaccination at at time point 0, 1, and 6 months as well. And in relating to sort of HPV, I want to talk a little bit about the varicella vaccination. So varicella is a common benign infectious disease in more often has been evidenced in the pediatric population, but it may be severe and even fatal in immunocompromised patients who are in the pediatric population and been diagnosed, for example, with CKD or end-stage renal disease. And so furthermore, zoster disease, a form of varicella, usually occurs in adult, also in adult and in the elderly population. Response to varicella vaccination has tested well in those on forms of renal replacement therapy, including dialysis patients, and it has been generally well tolerated in context of a protective form of vaccination. So varicella infection was also was frequent and serious amongst non-immunized post-transplant recipients. At least there has been data around this. For patients older than sort of 12 years of age, available guidelines recommend 2 doses, or at least historically in the literature, there has been evidence in context around guidelines that children or young people older than 12 years old should be recommended of 2 doses of 0.5 ml with no booster doses. So in context of the influenza vaccination, influenza is a common infection that is has been responsible for many deaths. Because of the virulence and pathogenic power of the virus, influenza vaccination has been recommended in and amongst the CKD population, and the risk of hospitalization or death is generally decreased in vaccinated renal replacement therapy patients, in particular those who are on, for example, hemodialysis versus peritoneal dialysis in some regard, owing to the invasive nature of hemodialysis versus peritoneal dialysis, and compared with non-vaccinated HD patients. And studies have demonstrated, or at least highlighted, that influenza vaccination is safe and effective in patients with CKD, despite where there can be an impaired antibody response. Vaccination against influenza is also associated with decreases in mortality and results in decreased sort of hospitalization. Antibody titers can be lower than in healthy population. However, satisfactory protective rates can be sort of identified and can be identified through appropriate sort of annual vaccination, and where appropriate and applicable. And the correction in relating to this, also the correction of vitamin D deficiency among HD patients can also improve the immune response. So in literature, a single dose of 15 micrograms has been demonstrated of decent efficacy in the CKD population. So I'm now going to move into talking a little bit about Staphylococcus aureus vaccination. And so Staph aureus is a major cause of what's referred to as nosocomial infection and community-acquired infections. And patients undergoing sort of forms of renal replacement therapy represent generally, unfortunately, high risk category of developing infection in relating to Staph aureus due to sort of violation of the skin barrier. And generally everyone generally has a sort of an amount of Staph aureus throughout through their skin and around their skin, for example. However, in those who have end-stage renal disease, patients may have impaired immunological response with about 50% reduction of IgG or immunoglobulin levels of 6 months post sort of vaccination. And so renal nephrology, those under sort of nephrology care or nephrology patients reach protective antibody levels only for about 6 months. And then there is no current sort of guideline or basis around particular modality around the vaccination of Staph aureus. However, there is some literature to inform that vaccination around Staph aureus, Staphylococcus aureus, can be advantageous. Now, I'm going to talk a little bit about pneumococcal vaccine, and so the burden of pneumococcal infection in CKD or ESRD patients can be quite high, and the cost of pneumococcal vaccination has been documented as being quite low. Pneumococcal vaccination should be administered to all patients with CKD as early in the disease in the particular condition as possible. CKD patients over the age of 19 years should receive a dose of pneumococcal conjugate vaccine 13, which has been sort of highlighted in literature, at least initially, followed by a dose of pneumococcal polysaccharide vaccine at least 8 weeks later. And the second dose of pneumococcal polysaccharide vaccine or vaccination is recommended 5 years after the first dose of it for a person's ages, any age after between 19 to 64 years. Adjuvant therapy is also something that is of sort of general intrigue. Another way to improve sort of the immunological response of vaccines or vaccinations in those in CKD or chronic kidney disease or end-stage renal disease patients is to use an adjuvant therapy to vaccination in order to stimulate the immune system. One of the most important investigations regarding adjuvant drugs was the granulocyte macrophage colony stimulating factor, or GM-CSF, and this can help prompt the proliferation and maturation of cells into granulocytes and macrophages, which are important in part of the immune response, both from a protective and from a sort of a tolerant immune response perspective. So I'm going to close this audio podcast on that note, just again, once again, I'm just going to highlight a few acknowledgements here, and there's colleagues between an academic institution and the renal patient support group, the RPSG, and the kidney disease and the kidney disease and renal support group, or KDARS for kids, who together when we co-developed the slide set, and once again, this has been the Shientist, and this has been part of the LabTronix series, and it's been another Storm Robotics production. Thank you.